Welcome, Health Impact audience. We've got a great next 30 minutes to talk about a really cool angle around telemedicine. Obviously, in Health Impact Summer, which we had a couple of months ago, there was all the rage about how there was a huge spike on patients using telehealth, physicians enjoying telehealth. But we haven't really spent much time talking about a really different angle on telemedicine, and that is, how do physicians talk to physicians? How do medical device representatives who need to be in an operating theater be able to participate in a surgery without being in the operating theater? Now, why are these things important? Most hospitals today are trying to keep as many people out of the hospital as possible. Now, there are people that need to be at the hospital, like the physicians, the nurses, and all the people that have to staff operating theaters and emergency rooms and things like that. But as many of us know in the industry, people who make medical devices often send in sales reps. There are device manufacturers who have to have representatives inside surgery rooms when those devices are being used in a surgery, so that they can be monitoring and making sure that the safety is being practiced properly. Well, all of this requires people to come into a hospital. They have to be tracked as a representative. They have to get those, labels onto their shirts. They have to go up to the room. They have to be moved around and shuttled in the room. So all of this stuff, just so safety can be monitored, creates chances for infections to occur. They create chances for errors to occur, rescheduling to occur because of people that are in the surgery rooms that don't need to be there. Well, we were just talking with Daniel very recently, and he's got a very cool new system that can help reduce the need of actually having people in the surgery room, but increase the quality of any telepresence, et cetera, associated with these people. So number one, Daniel, welcome. Please introduce yourself. And before I ask you some more questions, just tell us a little bit about your company as well.
Appreciate the chance to chat, and thanks for the opportunity. So by way of background, I've been in the medtech space now 26 years. Started initially in angioplasty, and have been involved in with a large company, and have been involved in a number of startups. My whole career has been focused on clinical medicine and the devices associated with clinical medicine and the needs of care providers, not only physicians, but hospitals, to leverage technology to improve patient care. For the very first time, I'm actually now leveraging technology to improve the efficiency inside of medtech as well as inside of hospitals, by creating a new version of telemedicine that we call procedural telemedicine, that enables industry and outside clinical experts to participate live, real time, in procedures in an operating room without having to physically be there.
That sounds very cool. And you've mentioned this as almost democratizing access to expertise. I find that very fascinating because there are multiple parties in the network, right? So I believe you guys take equipment at your cost. You put it into the hospitals and health systems. So there's no cost associated with hospitals putting any equipment. Once the equipment is there, you can then allow anybody from almost anywhere to be able to connect into those devices, be able to then control cameras, be able to control where the angles are that people are looking, potentially even record or manage documentation remotely that can then be sent to compliance. Tell us a little bit about what is a surgery with your devices in there look like, and what's happening in the room at the time.
Absolutely. So we do in fact put equipment. These are telemedicine consoles with 2 cameras, a large screen associated with them, boom arms. We have plugins in the back for intraprocedural imaging. You should be thinking laparoscopes, robotics, screens. You should be thinking echocardiograms, angiograms, and the like, plugged into the back. All of that creates a media-rich environment of high-definition audio and video that is now securely, HIPAA compliant, encrypted, transmitted to a remote person who then can access all of those sources of video and everything that they do on a screen through either an app or access to our portal online on a laptop or a desktop Everything they do on that screen, selecting videos, freezing frames, split screens, they can draw on the screen for instruction purposes, they can remotely control cameras, but everything they see is transmitted back to the hospital and displayed on the screen for the in-procedure room care team to be able to see. So that allows somebody remote to control the whiteboard, if you will, and fully, very richly provide clinical input into a procedure. Today, we do not record. We will enable recording in the future. We do not connect to the EHR. Right now, what we're doing is a pure live case experience. The goal here is, in fact, to democratize access to expertise. We all know that within a health system, multiple facility health system, or even across health systems, there's pockets of highly specialized expertise. Certain case presentations, certain clinical experience associated with a new technology that you'd benefit from if as a physician who's new to that type of case experience, case presentation, or new to that technology or technique, you'd benefit if somebody were in the room. There's a lot of logistics to get somebody in the room. Today, there's concerns around infection control. Regardless of COVID and pre-COVID, and I think will persist in the absence of this type of a solution, there's logistical challenge that prohibit folks from being able to do that. You should be thinking in rural communities, or even simply in cities, in New York City, to get a physician from Columbia to go down to NYU, that's a half a day proposition. In our system, it's 25 seconds to log on. Click, click, you're in the room. You can be in the room for 5 minutes, 45 minutes, 3 hours, whatever it is, using our system, sign off, get back to your day. We democratize access because we eliminate the need to physically be in a room. But we give you all the tools you need to do everything you needed to do if you were in the room. You control your view. You control what the different types of imaging you're looking at. You can freeze frame, can't do that in an operating room. You can split screen, can't do that in an operating room. You can draw on the screen and provide didactic information to be able to help the clinical procedure progress. You also can't do that in a room. It's useful for physician to chat with physician, and it's incredibly useful for industry to participate in procedures without actually having to be in the room.
Yeah, that I think, let's start there, because both you and I have spent a long time building medical devices, yes. And it's a massive headache to get people in and out of the procedure rooms. Not just the logistics part of it, but the cost, right? So yes. It could be that for industry, if their devices cost $1,000 per procedure, 10%, 20%, 25% of that cost could be borne because of the rep needing to be in the room. Is that about right? Like, how expensive is keeping a rep in the room for people who make medical devices?
It's extraordinarily expensive. And of course, that cost is in one form or another passed on to the hospitals. So one of the things we're trying to solve at Avail is look, I've been in this business, again, 26 years. I've gotten a fantastic appreciation for the multiple constituents involved in technology deployments in hospitals. And one of the things hospitals need to be concerned about is, of course, the cost of care delivery and the value of the clinical advances against the cost of those clinical advances and how they need to be appropriately used and the like. But one of the challenges, of course, is what you just described. When you purchase a stent, you're purchasing rep support. It's not a line item on the PO. It's baked into the cost of that stent.
Right.
When you purchase a knee for a knee implant, you're not getting a line item saying clinical support on there, but you better believe the cost of the rep that comes in, you're paying for that. And we know that. And industry knows that. It's an extraordinary expense for industry that has been estimated to be 20% across the industry, 20% of the total revenues in med tech is spent on that one category on a fully burdened basis, that one category of field-based support. It's extraordinary. For a $200 billion industry, $40 billion is spent on that topic. Now here's the rub. when you actually get down to the biclinical area level, down at an angioplasty, about 17% of the cost of a stent is baked into the people that come into support. When you go to orthopedics, CRM, meaning cardiac rhythm management, pacemakers and the like, and you go all the way into spine, it can be between 30 and 40% of the cost of that implant is all the service that is tied to it. And the vast majority of that number is the people in the room. Now, I don't believe, our company doesn't believe, and it's not, I don't believe clinically the right thing to do to be 100% repless. It's not a terribly easy thing to institute, and there are clinical challenges associated with that. Reps actually provide an extraordinary amount of value to clinical procedures. As every physician knows, they learn things from reps on a regular basis during procedures. The challenge, of course, is a balance between the two, right? Our system is designed to enable reps to be part of a procedure without having to be in the room. What does that do? It helps with infection control. It helps with access management. It helps with respect to, frankly, reps traveling throughout inside the hospital, and I think everybody knows that that's an issue. It helps with new product introductions that are off contract. That's a big one. For hospitals, that's a big one. And we know that. And then the last thing it helps with is actually expense, but it helps it somewhat indirectly. It saves an extraordinary amount of expense for industry because it's not well understood, but between 50 and 60% of the total time spent by a rep supporting procedures is actually the logistics, driving to a hospital, going through rep tracks and credentialing, going upstairs, getting on scrubs, waiting for the case, then waiting for the time in between cases, and then driving on to the next hospital to meet their next customer. 50 to 60% of their time is wasted. Using our system, that shrinks a lot. That saves money for industry. We believe that it can be transferable to a better cost structure for hospitals through device costs and device costs.
And I think that another area where you could transfer some of that cost to help the hospitals is, so the equipment that you have, the hardware, is in your network, right? The Avail network. And so industry pays you guys, you go and put the hardware into the hospitals basically for free. And so aside from, any tangential cost they might take on to let you guys in and out of rooms to manage the hardware, it's probably a low cost. But other than that, they pay nothing. There's no cost associated with the hardware. But what's really cool is since the equipment is already sitting in the rooms and is there, they can then use it also for one doctor in a facility to talk to another doctor at another facility. And what I find really fascinating about this is where training and education is part and parcel to so many academic medical centers that they just take it for granted. But even at the AMCs, they need to have the best trained doctors available in multiple surgeries simultaneously watching, whether it's the attendings, whether it's the advisors, et cetera. Talk a little bit about that. Let's assume for sake of argument that all the huge benefits that you provide to industry and the field reps just didn't exist. And we were just talking about the value of that free hardware sitting in the surgery room for hospitals. What would that look like?
So you hit the nail on the head. Education, it's called the practice of medicine for a reason, because you're always learning. In a procedure room, the old adage in the industry is see one, do one, teach one, right? So you see one, then you're ready to do one. Well, the reality is you kind of like your teacher over your shoulder all the time, right? Until you've done 30 or 40 of these things, you kind of prefer somebody's watching. And then you have a new case type come to you, a new presentation of a patient characteristic. You kind of want that friend there again. The reality is that what happens from the standpoint of technique and technology introductions and integration into care delivery happens in the OR. When our system is in there, it is in there providing access to a network of anybody outside of the hospital who has access via the Avail network to log on and be part of a procedure. Very importantly, though, with permission by the hospital, right? So we have a very clear process where If Dr. So-and-so wants to watch in a procedure, they need to be credentialed and permissioned, and we've got a way for the hospital that has the equipment to do that. We also make sure that industry can't spam call into an operating room, right? I mean, that's super important, right? I mean,
absolutely.
So we actually force it such that industry's not involved unless somebody in the OR presses, please call.
Right.
Then there's an outbound call placed. Industry answers the phone. They don't place the phone call, right? So we're clearly putting access control in the hospital that has the equipment resident. Yeah. And you are correct. We're not we're not charging for that equipment. We are paying for it and putting it in there and maintaining it and updating it. That allows then a network of these to be placed. Now, in a large IDN, there might be 50, 7,500, 200 hospitals. There's expertise, pockets of expertise all over the place. It is impossible logistically, and it's cost prohibitive, not just from the flight and travel costs, but the absence from being in clinical practice cost, the opportunity cost. It's impossible to get expertise from Omaha, Nebraska to Tallahassee, Florida. It's not going to happen, okay? And it doesn't happen. We democratize that access to that expertise, because if Tallahassee, Florida has one of our pieces of equipment and the physician in Omaha, Nebraska has an app, they can chime in. And if the reverse is true, they can chime in, right? One of the other beautiful things in academic settings, to the point that you made a moment ago, we actually have teaching hospitals that are deploying our equipment in ORs to be able to train prospective surgeons, not by the requirement today of being in the room. Because if you have a class of 15, you can't fit 15 prospective surgeons in a room and get effective teaching. You can't do it. So they have our equipment in the room, and then they beam that out to an auditorium where a professor of surgery has an iPad plugged in, and it goes to a large monitor, a large screen in a room. And now that professor of surgery is directing through our system a conversation with the treating physician, and a whole bunch of prospective surgeons are learning. That's a great academic environment. Now I'm going to blow that up and say digital grand rounds. Why couldn't you have, if there's a new technology introduced in my example of an IDN, a new technology introduced in Tallahassee, Florida, and the physician in Omaha, Nebraska, and one in New York, and one in Texas, and one in California, all want to watch the first usage of a new technology or the first type of a particular patient who a new technology is being deployed to, they'd be able to watch. They'd hop on and be able to watch and interact directly with one of their clinical colleagues in another hospital in Tallahassee. They're able to walk through all their questions because it might be next week or next month. They're going to have the same technology. Then they can ask that physician in Tallahassee, hey, can you help me out of my first case? All of that bouncing around happens on our network. And when our systems are deployed in hospitals, all that conversation is now fluid. That can happen very, very simply on our network. And much like with industry, hospitals would pay for access time associated with that on a different rate structure than we charge industry, but it's the same kind of model, and we maintain and own all the hardware.
Yeah. So another area for hospitals who are right now, very tight on funding, very tight on revenues is elective surgeries have been pushed. People need to start rescheduling those elective surgeries. And this problem gets even more and more acute so you have a whole bunch of procedures that were paused. Now these procedures have to be scheduled. But if you had this type of equipment with telemedicine available, you'd have one more little knob you could turn and say, you know what, I don't actually need everybody at every physical room. I can get one guy in 3 areas, and now the scheduling becomes easier. So given all the backed up elective surgeries, is what I just said makes sense? It can actually help reduce the time to reschedule some of those items?
It does, and it does because many of the elective surgeries require industry to be in the room.
Okay.
Many of the elective surgeries would require consultative help from another physician. And the scheduling of all of that with the physical logistics is really a challenge when, okay, so COVID shut everything down. and you might have had a whole lot of procedures set up where you might have clinical expertise delivered by another physician because you scheduled them to be in the room. Well, now that everything's not shut down, knock wood, it stays that way. Yeah. But now that everything's not shut down, it is in pockets, but in general terms, it's open. Now you have that same physician who might have been available to be able to provide expertise is swamped. They can't get out now. So now what do? From the industry perspective, where industry needed to be in the room, they're swamped because they're used to X level every month, and now they had a number of months with nothing. So for a handful of months, they're at 4X, 5X, 10X. How do they meet all of those customer demands for elective procedure support from industry, from their sales reps, from their clinical representatives, if they got to be in the room? When our systems are there, now you can actually pepper in that expertise where a sales rep literally in a home office can be on one side of the state from 7:45 to 8:15 in the morning, on the opposite side of the state from 8:25 to 9:15 in the morning. They couldn't do that physically. Now they can through our system. And you can imagine that elective surgery backlog coming down, 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 down to a normal.
Yeah, that sounds fantastic. And so we've got a few minutes before, then we're going to open it up for questions to our live audience. What are some ways for hospitals to maybe use this potentially as maybe additional revenue? So obviously they're paying you for the time. No, they don't have to pay for the hardware, but they're paying you for the time that they need to be using on the network. But I can think of a few options. So for example, the education one, if the hospital wants to do teaching, they can actually sell that capability to other hospitals and charge other hospitals or other doctors to learn from them. That's one area. Another area is if the same physician can be at now 6 surgeries, that physician is making more money to bring in and be an advisor on multiple surgeries. So just in the last couple of minutes that we have, tell us how, just to do some future thinking here, even if you don't support it today in your device, you can imagine that there's tracking going on. How could this help reimburse for all of this extra time that you now have in order to spend at multiple surgeries?
Sure. So one of the ways to think about that is there's a very, very hard push to move procedures into ambulatory surgery centers. And one of the challenges, of course, is you need to staff all those ambulatory surgery centers. One of the further challenges is expertise is not 100% the same for each physician. Mm-hmm. So now if you envision you had a group of physicians that did most of their procedures in an acute care setting, and now a third or a half or more of those, I'll pick on orthopedics because there's a lot of codes that transferred over in ambulatory surgery settings, as well as primary angioplasty in January. So now a half or so of those procedures might be in 5 different ambulatory surgery settings. Okay. You'd like to be able to normalize the care capability across all of those settings. The challenge, of course, is not each physician has 100% of the expertise of the collective group of physicians. So what you really want to be able to do is participate in those procedures. And if you can participate,
can you bill for them?
Well, if you're doing it within a state, there would be opportunities because it's within a state. Now, you have to follow local telemedicine rules and what have you. Our system is not designed for reimbursable care interactions in that way, like there are stroke solutions and whatnot that are for emergency care, stroke differential diagnosis and whatnot. This is more that there be a practice group or if they're hospital ASCs. If you can treat a broader type of patient population in the ambulatory care centers, now you're able to generate greater revenues, right? Because you're able to disseminate that expertise. I'll quickly touch on the education for just a moment. There are a number of facilities that have asked us to record. We're working on that. It needs to be HIPAA compliant, all the IT security. We're not going to do that until we believe it is Fort Knox ready. Okay, but when we are, you envision a world where you're recording and you have a branded hospital-based recording of a certain type of procedure and expertise, branded with hospital, powered by Avail. That creates a media asset, if you will. That then becomes a really interesting commercializable media asset that we're building a platform to be able to work with hospitals to commercialize that. that's a very interesting additional revenue stream for a hospital based on the very, very good care from their physician base.
Right. And even if your hardware or your equipment isn't doing the time tracking and other things, if you could have been reimbursed for the time before meeting in person, it's very possible for hospitals and health system to think creatively, use this equipment, and obviously
Yes.
legally and under all proper compliance and regulation, consider being able to bill for time you wouldn't have otherwise billed because you couldn't have gotten the doctor physically
Yes.
to a location, and now you could have. So that's a great place to leave us here. We're opening the questions up to our audience. Please ask Daniel, try to stump the speaker here on how to create a more safer, but at the same time, more productive and more efficient hospital and surgery room and hospital in general. So with that, thank you, Daniel, and we'll open up for questions.
Thank you.
Daniel, you've got some great questions already queued up. I don't know if you've seen them, but I'll read them out to you. First one was from a good friend of mine, John Lynn. He was asking, before COVID-19, what forced reps to be in the room? Was it convenience for the doctor who said the rep needed to be in the room, or did the rep want to be in the room to provide better feedback to the doctor?
So that is a great question. It depends a lot, frankly, on which clinical area you're talking about and type of procedure. Medical devices have historically been used to improve care and with that, of course, change how a procedure is performed. Every new addition of medical technology that is clinically useful and valuable requires a measure of training. In order to do that, the industry, in many respects, has trained the clinical community to anticipate support to be able to use new technologies, and that became the foundation for relationships that have been built. So there's really a combination of two things there. The first one is every time there's a new technology introduced or a new technique introduced, there needs to be a bolus of training that needs to happen. Then the next thing that comes in is really a what I would describe in some respects as a preference. I have X number of procedures this week. I expect to see John Smith, my rep, in here, and when he's in on this type of a procedure or that type of a procedure, I'm going to have a couple of questions for him. It might also be that the rep wants to come in and chat with a physician in the middle of a case because they want to be able to help the physician understand the device they've been using for one category of patient regularly can actually be also used slightly differently to get a slightly different outcome for a slightly different category of patient. And it might be that there's a little technique tweaks, modifications that happen live in procedures. I've seen so much of that in my career and seen the incredible value that reps provide with that. That's really kind of the underpinnings of why I wanted to start Avail and make this something that is ubiquitous and easy to be able to do remotely.
Yeah, that sounds great. And by the way, if anybody wants to come on to the video to talk to Daniel directly, please just raise your hand and we'll flip your live video on here. The other question came in from Thomas. He said, nice technology. Any product designer would love to hear that. He's asking about latency, though. So he said, usually these technologies have annoying video latencies, for instance, live X-ray monitor versus these double transmitted views. So comment on that. And then I think you've got a bunch of other technologies that can allow other devices to hook into your device to even maybe play their video, not their images on your device. So talk about the latency and then the extra features as well.
Sure. So we actually built our platform to have latency that is less than half a second. So human perception is between half a second and 1 second. You can actually perceive the latency differential. We've built our platform in a manner that takes latency to less than half a second. So it is as real time as you can, from the perspective of human perception, actually be aware of. That said, of course, if you've got a really poor connection on one side or the other, that latency is going to have some differentials to it. Our system actually, before we allow a call to happen, we do a baseline network test on the remote. It's just part of the software. And it needs to be above a certain threshold, or we'll send an advisory to the remote user and say, please, please find another location or plug into a Ethernet or whatever it is if you're using a computer, but essentially improve your signal quality. There's also that other element relative to signal quality or signal strength. Everybody knows this, right? You start a Wi-Fi on your phone or your tablet or something, and then it goes down 10 minutes later, and then it goes up again, and it modulates all over the place. Our system actually works within that. And what we'll do, rather than have latency, is we'll tune down a little bit of resolution on the tiny picture in the bottom right-hand corner, like you have on your phone when you're doing a FaceTime. You got a little picture of yourself in the corner. We put one of those too. If we have to, we'll shut that off because that takes up bandwidth, right? What we don't want to do is interrupt the quality and the real-time nature of the video image transfer from the OR to the remote user, and the remote user back with the annotations and drawings on the screen back to the operating room.
Yeah.
In terms of the images that go into the back, plugged into the back, they're simply another video feed for us. Our system is designed to take all of those images in real time and transmit them with the same level of latency, if you will, half a second or less, and enable a real-time interaction back and forth.
What are some examples of those? Because you mentioned a few before during your talk, but remind us again, what are the extra devices that you can connect in, and why are those useful?
So when you're in an operating room, or a cath lab or an EP lab or what have you, you're looking at monitors. If you're not just staring at the operative field like you would in an open surgery, you're looking at monitors. Those monitors might be in a minimally invasive surgery setting, might be a laparoscope, the screen on a tower from a laparoscope, because the whole surgery is being done via a scope. It could be in an orthopedic setting, an arthroscope. It could be also in a general surgery setting or any type of surgery. Frankly, it involves robotics. It's a feed from the robot. Where you have a video feed from the robot. In an angiography suite, it could be angiograms, it could be echocardiograms, it could be a variety of different, what I would describe them as, imaging modalities, where either they're being used to conduct the surgery itself, like that is what the surgeon is looking at, or they're for reference during a case. All of those get plugged into the back of our system and via a standard HDMI or DVI cable interface, and we simply take that as a video feed. And then all of the hardware in our system and the software that we've a proprietary software we created packages up all of that and transmits it remotely with a half a second or less latency.
Got it. Yeah, true remote patient monitoring.
Exactly.
Eric has a great question. He's curious about how Avail's system differs from other OR companies, like OR company offerings like Olympus, Karl Storz, etc.
Okay, yeah. So all of those technologies have some basic capabilities that are not, I'll describe it as significantly dissimilar, in as much as they have cameras and they have screens, if you will, in the procedure room. And there's a capability to have some type of a remote interaction. Our system has been purpose-built for mobility and purpose-built to enable interactivity in a manner that none of the other systems before our introduction have been able to do, and none since, frankly. There's over 400 years worth of marketing and sales, medical device marketing and sales experience that went into designing not only the hardware, but more importantly, the software platform that enables a very intuitive, easy to use, and very importantly, mobile experience that is built for interactions that range from 2 minutes to many, many hours. I could train you, Shahid, in 5-6 minutes how to use the system. And when a phone call comes in from a hospital, you tap accept, you'd be in the room, you'd be able to move the camera, zoom the cameras, telestrate, split screen, freeze frame. All of those things are quick, easy, intuitive to use. We've also built, from the standpoint of industry being able to, meaning medical device companies, everything from orthopedics and CRM and what have you, we've built a portal platform that allows scheduling of availability down to the hospital level, down to I'm available, Tuesday afternoon between 1 and 1:30 for this hospital, and 1:45 to 3 o'clock for this other hospital. And our full network will accept all of that information and beam it down to the appropriate console to make sure that my name as a rep shows up in green on the console because I'm available for that procedure. So when it's tapped, I will answer. All of that is an ecosystem. All of that is built to enable this type of interaction. The same capability on scheduling is possible for clinicians to talk to one another.
That's awesome. We are unfortunately out of time. We could have talked about this for a long time, but please, anybody on the chat room here, please reach out to Daniel. They've got some really cool stuff. It's not only pertinent just due to COVID, but even without COVID, it would have been super, super pertinent, even more so now. We're jumping over to our next session, which is about innovation in pediatrics. So please join us over there, and we'll get that kicked off in about 30 seconds. See you over there. Bye. Thanks, Daniel.
Thanks very much. Take care.